Now, it is my huge pleasure to introduce my previously full-time colleague and still part-time colleague, Dr. Allison Boyce. She's recently had an improvement in her title to be chief of the Metabolic Bone Disorders Unit at NIH. And she has been just a unbelievable font of knowledge in helping my kiddos. So this is a particularly happy day for me to present her to you. So we thank you, Allison, for being here.
Great. Thanks so much, Laura, for that kind introduction. I'm going to go ahead and share my screen. Are you able to see that? Great. All right. Well, again, thank you again for the introduction and for the opportunity to speak on this topic. These are my disclosures, and I'll also note that essentially all of the treatments in children I'm going to discuss today are off-label. So pain is something that we all intuitively understand, but it's surprisingly tricky to define. The main organization that's taken on the task of defining pain is the International Association for the Study of Pain. And here you can see their 2020 consensus definition, an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And this is actually the first time the IASP has updated their definition of pain since 1979. And the words here in italics indicate the language that was added in 2020. So the reason for this update was to better convey the nuances and complexities of pain and to emphasize that pain is a subjective experience that someone feels, and it's not necessarily synonymous with activities in a neuron. So a quick review on the nervous system. It's divided into two parts. The central nervous system includes the brain and spinal cord, and the peripheral nervous system includes neurons everywhere else. Different types of pain are classified according to where they signal within this system. So the classic type of pain that most of us think of when we think of pain is nociceptive pain. This occurs when tissue damage activates nociceptors in the periphery, so either the bone, skin, or other tissue, which then sends signals through the peripheral nervous system to the spinal cord, where it's processed in the brain in the sensory cortex of the brain. Nociceptive pain usually presents with sensations such as sharpness, stinging, aching, or throbbing, and it serves an important protective function in the body to protect against further tissue damage. Treatment for nociceptive pain is usually anti-inflammatory drugs such as nonsteroidals. Neuropathic pain arises due to a disease or a lesion in either the peripheral or central nervous system. And this type of pain usually presents with sensations such as burning, paresthesias, numbness, or hypersensitivity. And this is a maladaptive process. It doesn't serve any helpful function in the body. Treatment for neuropathic pain is very different than nociceptive pain. It usually involves neuromodulators like anti-epileptic drugs or antidepressants. And the least common and most poorly understood type of pain is nociplastic pain. And this is a diagnosis of exclusion. It refers to pain that is associated with no evidence of nociceptive stimulation and no evidence of nervous system diseases. So examples would be fibromyalgia, irritable bowel syndrome, or nonspecific chronic back pain. And the treatment for nociplastic pain is complex and usually involves a combination of medications and therapy. So fractures are an event that can cause both nociceptive and neuropathic pain. So in the setting of an acute fracture, mechanosensitive nerves in the periosteum of the bone will release factors that will amplify the signaling from the peripheral nerves to the spinal cord. These factors also sensitize the peripheral nerves. So normally innocuous stimulation that wouldn't normally be painful, all of a sudden becomes noxious and painful. An example would be if you even slightly jar a limb that's fractured, that's very painful for the patient. And this is an example of nociceptive pain. In chronic non-healing fractures, these factors in this repetitive stimulation can lead to increased sprouting of sensory nerves in the periosteum and the callus. And so this can lead to neuropathic pain. So an important aspect of chronic pain is that it evolves over time. And this is sometimes called the chronification of pain. So if there's repetitive signaling from these tissue nociceptors over a long period of time, 3 to 6 months or more, the information actually gets amplified. So you have more information going to the central nervous system. And here, increased excitability in the central nervous system leads to more neurotransmitter release. So these neurotransmitters will activate neurons called glial cells, and these cells then release pro-inflammatory cytokines that lead to extravasation of lymphocytes and monocytes, which can lead to local edema. So this is a process called neuroinflammation in both the central and peripheral nervous system. So the net effect of all of these processes together is an increased sensation of pain, even if there hasn't been any change or worsening in the patient's underlying disease state. So the causes of bone pain in rare disorders are many. We can have orthopedic causes such as fractures and deformities or problems with surgical hardware. We can have metabolic causes such as hypophosphatemia, high bone turnover. Patients may have functional issues related to abnormalities in gait and muscles. Neurologic pain may arise from nerve compression or chronic post-surgical pain, as well as inflammatory causes. And while this may look like a neat laundry list of causes that we can tick off, the reality is usually much more complex. So pain in most patients with rare bone disorders is multifactorial, and these different causes of pain can actually interrelate to each other and lead to more pain. So it's a complex clinical picture. And just to illustrate this complexity, I thought it might be helpful to go through a few of the conditions that we commonly see in the pediatric bone clinic to look at the different causes of pain. So osteogenesis imperfecta is a bone fragility disorder caused by mutations in collagen type 1 and rare other genes. In OI, we have reduced bone formation, which you can see here with these thin and sparse trabeculae, as well as relative increased osteoclasts, leading to a state of high bone turnover. Although fractures are very common in OI, interestingly, non-fracture pain is even more common, affecting up to 86% of patients, and is associated with a poorer quality of life. And non-fracture pain interferes with activities of daily living in about half of patients. So in OI, we can have pain due to joint issues. Collagen is an important component of tendons and ligaments, and it's common to see instability and hyperextensibility in joints, as you can see in this child here. We can have skeletal deformities such as scoliosis and spondylolisthesis. It's common in OI to see this type of hyperlordotic deformity, and patients can also develop painful vertebral fractures. OI has a craniofacial phenotype, which can lead to neurologic complications such as basilar invagination and trigeminal neuralgia. Duchenne muscular dystrophy is another condition we commonly see in pediatric bone clinic. This arises due to alterations in the dystrophin gene, which leads to progressive muscle degeneration. So we can see that muscles are affected by inflammatory infiltrates, which leads to swelling, fatty replacement, and degeneration over time. So this can contribute to pain. We can also see pain due to complications from prolonged immobility, such as joint contractures. And then we can also see painful vertebral compression fractures and scoliosis. So in Duchenne's, we see chronic pain in about half of patients, and pain is associated with poor quality of life, function, and sleep. So fibrous dysplasia is a disorder that arises due to impaired skeletal stem cell differentiation, leading to mosaic bone lesions. In FD, we see large areas of abnormal bone formation with this woven bone, fibrous tissue, as well as prominent osteoclastogenesis, leading to a state of high bone turnover. Pain occurs in about 80% of adults with FD and about 50% of children, and has been associated with impaired physical function. So in FD, we see skeletal deformities, which can impair ambulation, scoliosis, as well as leg length discrepancies. We can see craniofacial expression, which leads to nerve compression and other neurologic causes of pain. And also, FD tissue overproduces the hormone FGF23, which can lead to painful rickets and osteomalacia. So even within these rare diseases, we can see multiple pain types. In osteogenesis imperfecta, both neuropathic and nociceptive pain are common. However, only nociceptive pain is associated with decreased physical function. In children, interestingly, there's no relationship between the type of OI and either the presence or the intensity of non-fracture pain. Fibrous dysplasia also can present with both nociceptive and neuropathic pain. In FD patients, neuropathic pain is associated with having higher pain levels and worse quality of life. And similar to OI, we don't see any relationship between pain and disease severity. So even patients with trivial amounts of FD can have severe pain, and patients with severe FD can have very little pain. It's not consistent. So given the multifactorial nature of bone pain in rare bone diseases, the clinical approach really needs to be quite broad. And it starts with the history. It's important to take a detailed pain history, including understanding the onset of pain and its inciting events. We look for the location of the pain, where it radiates and its quality, want to know aggravating and relieving factors, any associated symptoms, as well as a detailed medication and review of systems. The physical exam focuses on the musculoskeletal system, so looking for strength and range of motion, evaluating gait, the hyperextensibility in skin and joints, as well as skeletal deformities. For imaging and labs, we focus this more based on clinical concerns. So orthopedic pain is common in rare bone diseases, and so it's something you don't want to miss. And this often requires imaging, such as either radiographs, CT, MRI, or a functional scan like a bone scan. And labs, again, need to be targeted based on areas of concern, but often includes things like a vitamin D or chemistries, bone turnover markers, and inflammatory markers. So assessing pain in children involves three main steps. The first and most important step is self-report. Whenever possible, we try to take the pain history from the child themselves. This also involves use of a developmentally appropriate pain scale. And there are two main types of pain scales. The most common one measures pain intensity. So I think most of us have seen this Wambaker-Facey scale that is often on the walls in your hospital. And this allows kids to point to the face that corresponds to the intensity of their pain. So these are numeric. A more complex approach is the multimodal pain scale. This also includes information about pain quality, triggers, and the impact that the pain is having on the child's daily life. There are a number of different validated questionnaires for children, including PROMIS and BAPQ. Multimodal scales are really important for children who have chronic pain. The second step is behavioral indicators. And this is something we usually get from parent or guardian report. And it's important to get information about changes in sleep, appetite, energy, and social behavior. And the third step is to look for physiologic indicators of pain. This is something we get from the physical exam. So we look at vital signs, including heart rate and blood pressure, vocalization, facial expressions. We're going to look at how the child is moving their body and different areas of muscle tone. And there's scales available to help for either pre or nonverbal children. This is an example of the FLAC scale, where you score based on face, legs, activity, cry, and consolability. And this is primarily used in the setting of inpatients or postoperative pain. So due to the multifactorial nature of pain in rare diseases, the treatment approaches, again, have to be broad and encompass a lot of areas. And one of the most important approaches is corrective surgery. So bone that is mechanically unstable is prone to fractures, deformities, and other pain. So a corrective surgery's goal is to preserve function and to decrease fracture risk. This often is a complex process and needs to take place in stages. So down here, you see a child with OI who underwent a staged correction of femoral bowing, which was complicated along the way by femoral fractures. Here we see a patient with fibrous dysplasia who had pain with weight bearing due to a mechanically unstable femoral neck, who responded very well to intramedullary rods and nails. However, it's important to bear in mind that surgery always carries the risk of leading to further orthopedic problems, difficulties with hardware, and can be its own source of pain. So physiatry is an important and often underused specialty in rare bone disorders. Physiatrists are trained to evaluate muscle strength in different groups, and this is really relevant in skeletal disorders because there's intimate communication between the bone and muscles. They both communicate mechanically and biochemically. So optimizing muscle strength is a really important part of management in rare bone diseases. And this is particularly true of core strength because that's important to optimize posture and preserve joint function and range of motion. I think we all have patients who sit like this because of poor core strength, and you can see that it puts extra stress on the neck and the back, as well as the heel cords. I mentioned a few slides ago about leg length discrepancy. So when weight is borne unevenly on the lower extremities, the body tends to tip the hips and the shoulders in an effort to keep the head straight. So this puts extra stress on the knees, the hips, the spine, the neck, which can lead to pain and other problems long term. And often low risk interventions like shoe orthotics can be very helpful. It's also really important to have a physiatrist involved in any patients who use assistive ambulation devices because poor positioning can lead to problems with the spine, joints, and other issues. So when we look at pharmacologic treatment of bone pain, we take a stepwise approach. Most clinicians will start with, for patients with mild pain, with over-the-counter medications such as non-steroidal anti-inflammatory drugs and acetaminophen. And patients who don't respond to over-the-counter medications and have moderate to severe persistent pain, escalation often involves considering use of intravenous bisphosphonates, such as alendronate and pamidronate, as well as other adjuvants that I'll discuss. So bisphosphonates are synthetic analogs of pyrophosphate. They incorporate into the skeletal matrix where they inactivate osteoclasts. They have a long half-life of greater than 10 years and have been approved by the FDA for treatment for adults with osteoporosis in an effort to prevent fractures, and in adults with skeletal metastases in an effort to prevent skeletal-related events, which include fractures and spinal cord compression. They're also used off-label in many pediatric disorders. So there's a fairly substantial body of preclinical evidence that bisphosphonates may be helpful for treatment of bone pain. And this seems to be related to bisphosphonates' inhibition of the enzyme farnesyl diphosphate synthase, or FDPS. FDPS is present, reduces the proton secretion, so the reduced proton secretion in osteoclasts who are treated with bisphosphonates leads to decreased activity in the acid sensing channels in the peripheral sensory nerves. So this leads to reduced bone's nociceptor signaling. FDPS is also present in macrophages and in glial cells, where its inhibition decreases the production of inflammatory cytokines. So this reduces central and peripheral neuroinflammation. So in humans, by far the most data for bisphosphonate treatment of pain comes from adults with bone metastases. And there was a Cochrane review in 2002, which included 30 studies and 3,682 adult patients, which did show an improvement in pain in adults treated with bisphosphonates. However, in 2017, the European Association for Palliative Care was critical of this review and performed an updated systematic review, which included 43 studies and 7,590 patients. And unfortunately, they found that the inconsistent trial designs really precluded the ability to perform a high-quality meta-analysis. So in most of these studies, pain was not a main outcome, and pain was also not typically included in the conclusion criteria. Also, the methods for assessing pain in these studies were really all over the place and very heterogeneous, making it difficult to compare them. However, they did note that out of 28 placebo-controlled studies, 22 of them found no analgesic benefit of bisphosphonates. So taking this together, this shows that there may be weak evidence to support improvement in bone pain in patients with metastatic disease. However, it's unclear if these pain improvements truly represent an analgesic effect of bisphosphonates or whether this might be a byproduct of bisphosphonates delaying skeletal-related events. Bisphosphonates have also been studied in a number of other skeletal disorders. There was a large meta-analysis performed in osteoarthritis, which showed no effect of bisphosphonates on pain or disease progression. A meta-analysis in osteogenesis imperfecta, which included a wide variety of bisphosphonates, which was not able to establish an effect on pain or mobility. A small meta-analysis in femoral head osteonecrosis in adults, which did not show an effect of bisphosphonates on pain or femoral head collapse. And a small meta-analysis in complex regional pain syndrome, which did show an improvement in pain. Recently, there was a meta-analysis performed in children and adolescents with a wide variety of conditions: OI, osteoporosis, osteonecrosis, CRMO, and various bone tumors. This included 24 studies for a total of 893 patients, and 20 out of 24 of these studies did show an improvement in pain. So taken together, I think again here we have weak evidence that bisphosphonates may be helpful for pain in some metabolic bone disorders. In general, when we compare bisphosphonates to the type of medications used to treat pain, bisphosphonates have an overall favorable side effect profile. So I do think that consideration of bisphosphonates is warranted for patients who have persistent, moderate to severe bone pain. However, we do have to bear in mind that there is not a strong body of evidence to support this. So this is a potential approach to using bisphosphonate treatment for pain in children. So in general, we use intravenous formulations, pamidronate and zoledronate. This hasn't been something that's been compared in a meta-analysis. However, there are a number of placebo-controlled studies and open label studies that suggest intravenous formulations may be more effective for pain than oral formulations. So when we approach a patient, we really need to kind of divide them into two groups. In patients who have an expected skeletal benefit of bisphosphonates, so these would be patients that have low bone density or an increased fracture risk, in general, we prescribe standard osteoporosis dosing. So this would be pamidronate every 3 months or zoledronate every 6 months. For patients who without an expected skeletal benefit of bisphosphonates, so patients who have bone tumors or femoral osteonecrosis, we want to use the minimum dose of bisphosphonates and the longest interval needed to improve pain, to minimize their overall bisphosphonate exposure. This table here was taken from international consensus guidelines in fibrous dysplasia, and it recommends starting with either pamidronate or zoledronate and giving at a low dose and giving a trial of up to 3 doses to establish pain relief. And then in patients who respond favorably, giving the next dose and interval at the time that the pain returns. And recommends stopping if patients do not achieve any pain relief after 3 doses. So we do have to bear in mind bisphosphonate effects on non-pathologic bone. So this applies to the population of patients who have localized disease, such as bone tumors or femoral osteonecrosis, because these patients have an overall normal skeleton and are having pain from a focal lesion. So the images here come from fibrous dysplasia. That's what I study, but I think are generalizable to a number of different localized conditions. So when we treat patients with bisphosphonates, we can expect to see increased bone density in their non-pathologic bone. We should also bear in mind the possibility of modeling defects. So these x-rays are from a 23-year-old with fibrous dysplasia who has one femur that's diffusely involved and another femur that's not involved, so has normal bone. He received high-dose pamidronate for 7 years during childhood, and you can see that the bone quality in the fibrous dysplasia bone is still quite terrible. However, he has really thick cortices in his normal femur. And also, the bisphosphonates were stopped while this patient was still growing. And you can see he's developed this subtle bowing deformity that starts at the junction between the treated and untreated bone. So this represents a possible modeling defect as a consequence of getting all of these bisphosphonates in his non-pathologic femur. Osteonecrosis of the jaw is an uncommon, rare side effect of bisphosphonates. It's usually not seen in association with osteoporosis dosing of bisphosphonates, and it's also not been reported in children or adolescents. However, it's important to bear in mind that when patients have painful bone conditions that are treated with bisphosphonates, they are likely going to be on these bisphosphonates for a long time into adulthood. So this was a 23-year-old man with fibrous dysplasia who had been treated with zoledronate during childhood for 5 years. And unfortunately, he did develop osteonecrosis of the jaw in young adulthood, in part related to some poor dental hygiene and other dental issues. So I'm going to switch gears a bit and talk about treatment of neuropathic pain. As I mentioned in the introduction, this is treated very differently than nociceptive pain. First line treatment for neuropathic pain is gabapentin. This is an anticonvulsant. It has a high affinity for binding sites in the brain, so it's felt that the mechanism of pain relief is likely related to altered neurotransmitter release. It's been well studied in adults with different types of neuropathic pain, including post-herpetic neuralgia and diabetic neuropathy, where it has been shown to be helpful. So there's not a lot of evidence for its use in children. However, given that it's safe and well tolerated, it's quite commonly used for kids with neuropathic pain. Amitriptyline is our second line medication. This is a tricyclic antidepressant, which acts by blocking serotonin and norepinephrine reuptake. It has a number of side effects, including dry mouth, sedation, weight gain, and vision problems. It's much more poorly tolerated than gabapentin, although it has similar efficacy for pain relief. So for this reason, amitriptyline is a second line option. I want to briefly touch on cannabis and bone because anytime you bring up pain relief in bone pain, this is one of the most common questions that we get both from patients and from clinicians. And there's a growing body of preclinical data that the cannabinoid system may be important in bone physiology. We find cannabinoid receptors in central and peripheral neurons, and we also find them in bone and marrow cells. So this includes osteoclasts, osteoblasts, and osteocytes. Also, endocannabinoids are proteins that are highly present in the bone microenvironment because they're produced by bone cells and by neurons. And there's evidence in preclinical models that these proteins influence bone mass and remodeling. However, the clinical significance of this system has not been well established in humans. Similarly, the therapeutic use of cannabis in musculoskeletal pain is very unclear. One of the main reasons for this is cannabis is a Schedule 1 drug in the United States, which means it's very difficult to perform clinical research. It requires quite a lot of red tape and is really almost prohibitive. So because of this, we really have not been able to study the differing actions of the different components of marijuana. There is evidence that cannabinol or CBD may have very different effects on bone than THC. Also, most of the studies, clinical studies, are of poor quality. They're usually limited to observational or retrospective studies comparing marijuana users and non-marijuana users. So this conflates people who are using marijuana for recreational versus therapeutic use. There are also a number of concerns about psychiatric and cardiovascular effects. So in any patient who is using cannabis and has bone pain, whether or not they're using it for therapeutics or for recreation, I think it's a good idea to have those patients involved with a pain medicine specialist. I also just wanted to briefly touch on opioid use in musculoskeletal pain. This is the other big controversial area. I think most of us are aware of the growing opioid crisis, and unfortunately, it's been driven in part by use in musculoskeletal pain. Over the past 15 years, there's been an inverse change in prescriptions of opioids and non-opioid pain relievers for patients who have musculoskeletal pain in the United States. And this is a really difficult treatment in bone pain because with use of chronic opioids, we see increased pain tolerance over time, and we also see a speeding up of the pain chronification cycle in long-term users. So it's important to bear in mind that opioids are a really essential part of management for acute and postoperative pain. Typically, they're not advised for chronic use by non-cancer patients. However, we also have to bear in mind that this is a really complex issue, and we want to avoid adding to the stigma because there's a lot of particularly older patients who were placed on long-term opioids by clinicians. So the medical field bears some complicity here. And I think that any patient who is receiving long-term opioids should be managed by a pain medicine specialist. So I'd just like to close by speaking a bit about the chronic pain cycle. So in patients who have chronic pain, and have pain with activity, they tend to avoid that activity in the future. And this can lead to progressive deconditioning, which leads to even more pain with that activity. But there's also a psychological component to the chronic pain cycle. So being in pain makes a patient feel angry, fearful, and anxious. And this can lead to depression and social avoidance, which then leads to increased perception of pain. So psychological interventions are really critical for patients with chronic pain. I think this is particularly true in children because we're trying to set them up to have tools and coping mechanisms to deal with pain over the long term. And indeed, there's been a Cochrane review in children with almost 3,000 children showing that psychological interventions such as cognitive behavioral therapy are very helpful in reducing chronic pain. This is my last slide, and it really emphasizes the multidisciplinary approach to pain management and rare diseases. So, orthopedic pain is very common in patients with rare bone diseases, and the consequences of missing it can be really disastrous. So having a good surgical specialist involved is critical. And I hope I have convinced you that physiatry is an important and often underutilized specialty. However, I'd like to make a pitch that the metabolic bone specialist really should be the team leader in patients with chronic rare bone pain. And when I say metabolic bone specialist, this can refer to a number of different specialties. It's often endocrinologists or geneticists, but can also include, surgeons, such as Dr. Tosi, who manage complex patients. This is anyone who is going to be the primary one managing and has the primary expertise in a patient with a rare bone disease. So the role of the metabolic bone specialist and what we bring to the table is that we are best equipped to understand the broad differential of musculoskeletal pain. We're also skilled at liaising with other medical and surgical specialists. We understand the importance of optimizing bone health and metabolism. And we're also the appropriate specialists to be prescribing and managing bisphosphonates. And these are very complementary activities to pain medicine specialists. So the pain medicine doctors understand the alterations in chronic pain processing. They are helpful for liaising with psychology and psychosocial specialists. A really important contribution from a pain medicine specialist is assessing for and treating neuropathic pain. This is something that can often get lost if you don't have a pain specialist involved. And also pain medicine specialists can prescribe adjuvant medications that will mitigate bisphosphonate use and help us get away with less bisphosphonates overall. So thanks very much for your attention. I'm happy to take questions.